Hello, everyone. Welcome back, and I hope you're having an amazing experience. I want to thank all the speakers and the survivors who've spoken so far today. I'm going to introduce this talk. Tamar Rodney is an associate professor at Johns Hopkins School of Nursing. Her clinical work centers on supporting families recovering from substance abuse disorders, internationally recognized for research at the intersection of intimate partner violence and traumatic brain injury and PTSD. Dr. Rodney investigates trauma-informed psychiatric care and biomarkers that may improve early recognition and response. She currently serves as the president of the International Network for Doctoral Education in Nursing and is the chair of Leadership Succession Committee for Sigma Nursing International, where she advocates global nursing leadership, mentorship, and excellence in practice.
Thank you so much, Katherine. It is my pleasure to be with you this afternoon, and thank you for allowing me to share this space and some of my work with you. I'll go ahead and share my screen. As Katherine introduced me, I am a practicing nurse and a clinician, and most of what I do is research and teach, of course, and I love it all. And so looking at how we bridge brain injury and intimate partner violence between screening, biomarkers, and trauma-informed clinical response is my topic. But I have to tell you that this wasn't where I started. And so it's been a journey of learning and recognizing how much work we have to do in this space. So I'm delighted to share some of the things that we've learned so far and maybe where we can go next, specifically centered around describing in depth the relationship between brain injury and IPV. And what are some of the implications for clinical assessment? And then I'll move into looking at some of the biological markers that can indicate both brain injury, trauma exposure, and mental health risk. And closing out with how we might apply trauma-informed principles to primarily improve early screening and ultimately have a better interdisciplinary response. So I'll start with some of the things that you already know, but I do think it's important just to highlight IPV, how it's been described, and what is often left out of this conversation. So it can be many things, and we primarily think of IPV as physical violence, sexual violence, less often so stalking, and psychological aggression. We also know that it affects women more than men, but the important thing is to remember that the numbers are very close. And in preparing for this presentation, I saw varying numbers, 1 in 7, 1 in 3, 1 in 4. The numbers do matter, but it's more important to remember that it affects the individual who is at the hand of the violence as perpetrated, but also their extended families. So while sometimes I think we fixate on the 1 in 3 and the 1 in 4, to think about the other individuals who are impacted when we see these numbers. My next definition before we get in depth in this conversation is brain injury. And we've struggled for a long time to decide what is a traumatic brain injury, what is a brain injury, what is concussion. And so for the purpose of this presentation, I'm going to put it in 2 different boxes. One, what is described as a traumatic brain injury, which is usually by an external force like a fall, a car accident, or sports injury. And sometimes we will interchange that terminology between it's a concussion, or it's a contusion, or it's a hematoma, or a skull fracture. And then we have what is considered non-traumatic brain injury. And so sometimes these are by internal factors like stroke or tumor infection. But if you go to where I highlighted, this is where I think IPV is sometimes buried in this conversation and not really called out. And I think the research and the evidence also reflects this, that one of the mechanisms of action for non-traumatic brain injury is a lack of oxygen to the brain, or a reduced amount of oxygen to the brain, which is going to cause injury. I think the ongoing joke in my head is that any injury to the brain has to be traumatic because it wasn't meant to be injured. So while we put it in traumatic and non-traumatic definitions, I want to say that any injury to the brain can be life-altering and should be taken seriously, and in many contexts is always going to be seen as traumatic. So who does it affect? We know it affects not just a singular person, but also those around them. So what is important for me is to think about when we hear IPV events, between 50 to 90% will involve head and or neck injury. And this is critical because this is where the overlap of brain injury comes in place. When we look at the individuals who are considered priority when IPV, 90% of those individuals are the ones who are going to be considered priority populations. This is not the typical presentation of who is considered priority populations. We usually think about older adults, individuals who are not adults, and individuals who might be homeless or unhoused. But frequently, a person who is a survivor of IPV is usually someone who is in a relationship, would be considered supportive, or the existence of a relationship is considered to be supportive, frequently with other family members. So not as an automatic seen as a person who would be a potential priority population. But within this population, what happens is that brain injury remains hidden. It's a consequence of violence, but it's not usually seen. And this is where I think we start the conversation of how do we get away from what is seen to integrate what science has evolved to be, to say neuroscience is important in this, screening is critically important. But when we know what we do should include what I'm going to context as trauma-informed care. So the overlap between IPV is, I want to say it should be known, but if it's not known, I will say that it's mostly the highest rate of head trauma is usually with strangulation, and it is often underdiagnosed because one, it's not seen usually. Two, because even if it's known, the stigma that surrounds it is so severe and is so shaming and so blaming that individuals don't want to talk about it, or it's never screened for. And this never screened for is important because individuals may walk away with different understanding. Maybe they're grateful to be alive. Maybe it's a chance for them to start over. And so the injury is sometimes pushed to the back of the mind or of life occurrences as a way to survive, as a coping mechanism. But what happens is that the fault and blame becomes time that passes. And so it's never discussed and even pushes that number up for underdiagnosed. So it's not that it didn't happen, more important things take its place. The overlap here, though, are sometimes soft, what I'm going to call soft shared symptoms. So not the cut or bleed or bruise that you can see. It's the fog. It's the, I just don't feel right. I'm not thinking straight. It might be feeling emotionally dysregulated, which could be, oh, I had a bad day. However, if we look at the biology of this, both of those are overlapping, meaning that there is a biological basis of things changing in the brain, which will manifest itself in what I'm going to call softer symptoms, which might not always be seen. So sleep issues, maybe mood swings, maybe not full-blown anxiety, but anxiety symptoms, depression symptoms, anger, dizziness. If we think about this in a critical social sense, these are all symptoms that with a bad day or with a bad encounter could be a part of our regular routine. And what I'm saying to us is that as clinicians and as providers and as family members, we have to pay more attention to these things because we now know that the scientific basis is that the overlap and softer symptoms do progress into what might be not so soft, but more difficult mental health issues, emotional issues, and physical issues, which ultimately contributes to poor health outcomes. Another difficulty with IPV is that it doesn't carry that bruise or blow like you see the picture on the right, which it's a traumatic brain injury, which maybe there's a hematoma, maybe there's a cracked skull. It usually is from repetitive events. But with repetitive events, you might not see the first one or the first two or 3, 4, 5, but this cumulative damage will ultimately lead to severe, prolonged damage, cognitive issues, motor issues, behavioral problems. And so while a single injury might result in a test because you have actual injury or memory of an injury to justify it, repetitive injuries, while it significantly increases the risk of chronic issues and long-term issues, usually don't get that attention because we don't have enough evidence to say it happened 5 months ago and the 6th month is causing the issue. So again, this repetitive cycle of having something happen to you, but it's not serious enough to probably go to the hospital or seek help, but over time, the results actually are worsening because it becomes chronic issue. So I'm going to take a breath there for myself while I'm going to walk you through what is the biological basis of how I have gotten to understand the effects of IPV as well as brain injury. And I'll share with you that, like I said before, I didn't know, I had an idea what happened, but I had to get deep into the biology to make it make sense, as I say to myself, by finding out what is the biology of this happening. So, as I shared before, it can happen in multiple different ways. We have aging, genetic factors, infection. However, one of the things that can cause injury is strangulation. Any injury to the brain triggers what is known as a neuroinflammatory cascade. So the brain says it's been exposed to a threat, and what the body's immune system is built to do is to recognize a burst blood vessel, lack of oxygen. It triggers off a chain reaction of immune response. So it's saying we need help. Once that threat is detected, it sends off specific molecules which induces an alarm to the brain's immune system to say we need chemicals to go and fight this attack. So these chemicals are known as cytokines and chemokines, and it spreads a message throughout the brain to say that we need help, we need to release other molecules to help the healing process, because that is what it's supposed to be. If we look to the center of the picture, we see that large point that says environmental factors. That is representative of the microglia, and its function is really, it's one of the immune cells of the central nervous system, and it performs a range of different roles, but it's really a surveillance to activate response. So it removes debris, it removes dead cells, but it's crucial for brain health. What happens in this state is, as I said, the repetitive action is that the brain might have had this insult, is trying to rebuild and to recover, but it got another one. And so when you are in a prolonged state of neuroinflammation or dysregulation, this is where it leads to ultimately neuronal damage or cell death. And that is what causes all of the different chronic issues that we're going to see. So it might be Alzheimer's disease, or it might be chronic depression, it might be anxiety. It's an inability for the body to cope with the load of stress or repair, which leaves the body in a state of neuroinflammation. I'm going to take it back to the real world and outside of your brain for a little bit to say, this is what is going on, but we don't necessarily have an immediate reaction to it. But if we went back to an individual experiencing strangulation, brain damage, temporary or permanent, can occur in as little as 30 seconds. And without getting too graphic, if we think about someone who is going to suffer by the hand of someone else by strangulation, this could be minutes. This could be aggressive minutes. And we know that brain death itself, the entire brain, can occur in 4 to 5 minutes. Which takes us back to that initial conversation that if someone survives, feeling like I've escaped death, there's a feeling of gratefulness that I'll move on. However, there might be left with temporary or permanent brain damage. So what do we do? And this is where I say screening is critical. It should be for everyone. Any victim of IPV, whether there is the immediate sign, the bruising, someone is fearful, we have to screen. Let them tell you no, and the second time, let them tell you no again. However, we know that there are tools available, and I think the responsibility of clinicians especially is to use these tools. When you start that conversation, that person might not be brave enough to say, yes, it happened to me, but they might also know that there are tools that they could self-administer. This conversation shouldn't stay with one particular clinician. It can't just be the nurse or the physician or the social worker. It needs to be everyone involved. And so what I'm saying is that this should be a change in policy in your emergency room department, in your victim shelters where you see a clinician, in screening areas, that all of these tools should be part and parcel of how we take blood pressure and how we take vital signs, to also have screening and clinical assessment for IPV occurrence and, when possible, possible brain injury. So I'm sharing with you my next screen, which pulls up some of the ones that are shorter. And I say shorter because it's a sensitive topic. So if you went for something like the HITS tool, it's 4 items. You can use it in almost any setting. And so these are all available online. If we wanted to go for a more in-depth tool, we could consider the danger assessment tool, which is at the bottom. So I'm saying to us that we have multiple different tools available at our fingertips. They're just not being used. So here's a paper version for it, but what else should we be doing? And this is where we go for biomarkers of brain injury. And this is one of the areas that I do my research in. Is I started out looking at biomarkers for PTSD in veterans, especially who've had a brain injury, only to discover that those same biomarkers are identical to individuals who have had a brain injury via strangulation, not just by a fall or car accident or blast injury. So in my work, what I found was similarly inflammatory markers IL-6, TNF-alpha. I didn't research much for CRP because of its instability, but I also did IL-10. And these are reflective of the body being in a constant state of neuroinflammation. What do they tell us, though, is what is important. They are telling us that the individual has been exposed to long-term trauma. So it's trauma that hasn't healed. Our other biomarkers, your S100B and your GFAP and UCHL1, are also indicative of neuronal damage. And so the presence of these in higher amounts are telling us that this individual is at risk. Not only have they had the injury, but they are at risk for other chronic outcomes. And so if we are lucky enough to get to do research on individuals and we see these biomarkers, it's telling us at minimum 2 things. This person is a victim survivor of brain injury and also potentially IPV, which would be the warning light to say we need to do more. The 2 disorders that it has been closely linked with are PTSD and depression. While this is severe, I take this with a grain of salt because it's not surprising, because the symptoms have such a high overlap. And we can always include in this conversation anxiety. I just want us to be cautious though, because while we're looking at full-blown disorders, that is not the goal. It is important to note them because it's diagnostic and it can help to explain some of the symptoms an individual might be having. However, simple seeing individual symptoms is enough to give us rationale to say this individual needs treatment or they're at risk of even worse outcomes. The conversation doesn't just stop at inflammatory markers, however, and neuronal damage markers. It gives you an idea of where we can continue to do research, what keeps us going. So we know what we need to hear is that the cytokine release involves these markers. So what are we looking for? We're saying that at a very cellular level, some of these are indicative of astroglial damage. And forgive me, the biology is necessary at this point. It's saying that these compounds or these cells that perform various functions. They are the chemical environment for our neurons, which is the very basics of our cell. It helps us to form the blood-brain barrier. It helps us with synaptic activity, how we feel, how we transmit medications, how we tell if there's pain or not. They're responsible for clearing neurotransmitters. And it is a part of our reactive response to injury. So we go back again to say, if these are not functioning the way that they should, the body will not heal. And so when there is damage, we will see cytokine release. When there is astroglial damage, we will see our elevated GFAP, S100B, and the shared pathways with PTSD and TBI is one of the most researched pathways to say that individuals are at higher risk for these disorders, having had a head injury by strangulation or direct impact. Why it is important to note these is that it gives us evidence of invisible injuries. And this is becomes so critical because it takes the burden away from the individual. They don't need to explain to you anymore that, yes, I did have a head injury and relive that trauma. You're getting biological evidence to say there has been an injury. Dictating the mechanism of injury at this point is telling you that it's far along, but the person is at risk. It also takes away the explanation of, why do I have a headache? Why do I not feel like I'm sleeping well? Am I the weaker version? Is my body not good enough to heal? Am I weak to be in such a relationship? So it helps to start shift that shame and blame and stigmatizing language is often linked to mental use to shame individuals who are survivors of interpersonal violence. Where we go in terms of other emerging research is chronic IL-6, which is one of your other inflammatory biomarkers. Also, along with CRP, C-reactive protein, has also been linked to depression and anxiety. I like to ask my students in a quiz-like format what is the most prevalent and disorder, mental health disorder, which frequently comes up with the answer of depression. And if you answer depression, you and them would be wrong. It's actually anxiety. The symptoms have a huge overlap, but I usually caution ourselves to say again, yes, the identification of a specific disorder is important. More important is the symptoms and the severity of the symptoms. And so we have higher C-reactive protein levels being linked to a greater risk of the severity of symptoms, and it contributes to depression and anxiety through the inflammatory pathways. So the others, low BDNF, so it's not always high, low brain-derived neutropenic factor increases an individual's PTSD vulnerability. So it's between high and low, and very often it's also between the balance of these cytokines. What it does, it gives us information that we can work with to say these are pathways that we get to help individuals. If we can start to combine what we know about biomarkers, what we know about imaging, what we know about what the individual tells us, it helps us to start detecting risk much earlier. We have done this very well for sports injuries. We have done it post-mortem for many football players. That's not where the goal is. The goal is to detect risk earlier and to provide support for individuals before we get the development of chronic diseases, which is not just mental health diseases, it's cardiovascular diseases, it's sleeping issues, it's all the pieces that we need to start going in a screening for prevention mode, not of the injury, but of what can come, because we have enough biological data to help us. And I am of the view that if you have the information, why aren't we using it? So in shifting gear a little bit, now that we know that we have biological data, we know the overlap, how do we have that regular conversation? What do we do as a third step to have this conversation with individuals? And I want to say it should be natural, but it's not. but what I'm going to call trauma-informed clinical response should always be individuals are survivors of trauma. The conversation has to always be different. So recognizing when there might be neurological and emotional injury and that they are interconnected. Safety is always first, and it does bear repeating that having a conversation the first time might not be appropriate. Allowing that individual the choice of when to disclose and allowing them to do that in an environment where it can be empowering is critical. Minimizing re-traumatization of the individual based on the way the question is asked, when it is asked, and where. And then always include multiple modes of treatment. It's neurorehabilitation, it is therapy, sometimes it's medication, but we have enough things at our disposal to integrate treatment options for these individuals. If I can put trauma-informed care into what I'm hoping is a more digestible format, I call it the 4Rs. And this was developed by SAMHSA. I think 2014 this was developed by SAMHSA. And the 4Rs walks us through the things that we should always remember when conducting trauma-informed approach. The first R is for realizes, which asks us to realize that the impact of trauma is widespread. It's not limited to the singular physical injury. Again, it's widespread to more than just the individual in front of you. It might be spread to generations, if not the individual in the room and the one waiting outside the room. Recognizing is your second R, which asks us to recognize how trauma affects all individuals involved. And that means it might be in different ways. It could be from empowerment, it could be from changing life course, it could be to being an advocate, but the differences in how it might affect them will be varied. The third R is for responding, and it's responding by putting this knowledge into practice, and it should inform everything that we do for that individual, but doing it in an appropriate manner. And the last R is for resisting, and it's to resist any mode that would be re-traumatizing to this individual. So the way we speak, the way, the where and the how. And I think it's a good start to always remember the 4Rs in going into any conversation or encounter with a person, to make sure that we practice what is trauma-informed approach. With these 4Rs comes five key principles that we should always be mindful of. And again, safety is priority. It's not a cyclical pattern, not to say one is above the others, but that all should be taken and when appropriate, repeated. So it's recognitions of issues important to the individual and their family, collaborating with all the important persons as identified by the person of interest, giving individuals the choice. Is it the choice to get treatment? No, it could be therapy. It could be wait, I'm not quite ready. It could be choice to get to safety. And the importance of building not rapport, but trust. If this individual is not able to trust you to disclose all of the key important elements, this is a process that has to be built, not forced. And that's always key. Like, I want to help you. Why won't you tell me? The approach to trauma-informed care and the principles requires that this is not a, I see you once or 15 minutes. It is a process, which might also mean that the clinician in front is not the clinician of choice, and we also have to be respectful of that. It's what I love about working in nursing is that not just that I get to work with colleagues, but is the idea of embedded interdisciplinary care framework always. So again, it has to be collaborative. The FNP has to talk to the PsycNP, needs to talk to the social worker, needs to talk to the physician, needs to talk to the pharmacist, because the collaborative care means that they get better care. And that's the simplest way that I can think about it. Why wouldn't I want to have all the experts in the room? which would include my researchers, because if I'm not reading what the research is putting out, I also won't know how to offer important literature to individuals to say, and this is how I'm making my decisions. Incorporating survivor-centered language and healing practice. And I'm happy to share these slides because sometimes I think just knowing what to say the first time, what does this mean? What if I say the wrong thing? And it's literally changing the way we speak. Instead of saying victim, we say survivor. Or asking the individual, what is the terminology you prefer? Tell me about your trauma. Avoid directing individuals to recount the traumatic events. They might not want to tell you. They may not be ready. Don't assume that you're the expert in the role. We want to help and we want to fix it, but we're not necessarily the right person to do so. Other healing practices to always emphasize is autonomy and self-determination. It remains the individual choice, and frequently coming out of a situation where choice power is taken away, this might be the first time to re-establish autonomy and self-determination. Offering mind-body therapies, we have options. It's not a pill can't always fix it. And always offering support, building that collaborative relationship, and that is where trust starts. So these are just a sample of ways that we can start that conversation, but be mindful that it sometimes goes against what we think of in regular language. Let me fix it. Let me help you. Tell me about this, because we're so desperate to help, but it's not always the right choice. One of the things that is quite humbling is that we often make mistakes. We might use the word victim. I'm like, oh my goodness, that's not what I meant. It's okay to apologize. It's okay to ask. Allow that individual to direct you. So where do we go from here? Knowing what we know now, where do we go? I feel lucky sometimes to be stuck in a lab, and I know not everybody thinks this is lucky, but to say that I can push the conversation forward by getting blood samples and looking for things that I might not know be there. But what I'm trying to do is to validate the biomarker, not one or two or three, but validate a panel of biomarkers that might be indicative of just IPV and brain injury. Maybe push this to where we can have wearable point of care technology. And I've said this multiple times, and this is my hope. And if it ever comes through, I'll feel very accomplished. But similar to how we test for blood glucose, could we get point of care technology where we're testing for these inflammatory biomarkers to say this person is at risk, which means that if it's available, we can do it again. And we don't have to go through a massive research study to start discovering new information. And ensuring that in every way I practice, if it's the slides that I teach with, if it's the way I talk to my students at clinical, if it's the individuals in front of me, to make sure that this language that I'm speaking of, being survivor-centered language and healing practice languages, is integrated in every way I practice, write, and teach. So it can't be just confined to how I talk to an individual. It has to also be the way I teach other persons. I will caveat all of this to say that it remains individual factors. All of these are standard except where the age might matter, where the individual might have individual psychological concerns that they need, or individual biological factors. They might have needs for emotional skills, or it might be substance use, it might be genetics. So throughout our lives, multiple individuals have different social and structural determinants, and they might combine to protect or undermine their health. And we just have to be always mindful of this, and that the risk of a person might manifest based on their individual factors. So at all stages of life, we have to be mindful that things are going to occur developmentally. And while we speak of adults frequently, this also applies to children and older adults. I do want to offer you some resources that, as I mentioned, we do have a full chart of of tools we can use, but here are also some hotlines. A conversation doesn't always start with a clinician. It might start with a phone call, and we have multiple phone call lines. That's where sometimes that conversation starts, and those are the persons are often trained to pass that information on to a clinician or a trusted party to get help. So I'll leave this here for different places that individuals can reach out to independently. And my last slide is just not to give you more reading, but more reading about where you can find some of the current research that's been done, and some of the ones that I have, or one of the ones that I have published to identify some of the biomarkers that we know are connected to brain injury and what are some of the outcomes, chronic outcomes that this might signal. And my contact information, if there's anything that you would like to follow up on for questions, I'm always happy to respond, and I say that with all sincerity. But I'll pause here and I'll be happy to answer any questions that you might have for me.
It's an amazing presentation, and as a MSW social worker, I so agree with everything that you said. I wanted to just ask a couple of questions that was earlier in your about 1:30, so about 20 minutes ago, someone asked, thank you for all the information. I wanted to ask how the mechanics of injury impact the individuals with any blood-borne illnesses.
That's that's a fascinating concept. So for bloodborne illnesses, it would have already triggered a cascade of healing because that's what your cells are meant to do. It would be elevated. And so frequently when I'm doing these studies, and when I said these studies, I usually do peripheral blood draws indicative of long-term trauma. So it's not CSF fluid that I'm looking at, it's usually in the blood. So if a person has blood-borne illnesses, it's going to look very different. CRP might be much higher. What you'll be seeing comparatively, extremely high levels, which might tell you this is an outlier, might ask you to ask additional questions. The samples are frequently, while we need more research in this area, sadly, I shouldn't say sadly, many of this research was done with male participants who are extremely healthy to begin with. Most of our information, thankfully, came from our military population, which spurred this idea that there is a connection between mental health outcomes and brain injury, which then extended to IPV. So I'm thankful for that research, but recognizing that many of those individuals are not your norm for healthy, that they are your absolute healthy. So we have to be mindful of how what we consider healthy individuals might look comparative to someone who has an autoimmune disorder or any other bloodborne illness. But in general, we'll be expecting much, much, much higher levels indicative of an inflammatory process or healing.
Thank you. And then a follow-up a few minutes later from the same participant. Moreover, what is the impact for people experienced IPV-BI who also have experienced brain injury from overdoses?
So the mechanism of injury is important. It is important because you might have diffuse injury, which is scattered all over the brain, comparative to a compact injury. So while I didn't go too detailed in the mechanism of injury, that any injury to the brain is going to cause almost the same cascade, it is important to consider what other external biological factors might be. For substance use, it's going to be different how they respond to treatment, which is going to be critical comparative to what might be a single physical injury, which would be a physical outcome. So a good history is always important. And I know I'm speaking to individuals who would agree with that, but all of those components matter, how they will react to treatment, what are their vulnerabilities, and which is why I included that second to last slide, that everything holds true, but what we need to be very mindful of is that everyone has their other vulnerabilities, which we should always be careful of. And they don't always disclose all of it the first, second, third time. And sometimes it takes years to actually get to the truth of what are other things that are going on with that individual.
I'm just checking. I don't see any other questions in the chat or in the thing. If you were personally to have unlimited funds, what's the kind of study would you like to see if cost weren't a factor?
Oh my God, this was my dissertation question. Who is that asking me that question?
That was
This
me.
was,
I just came up with it.
oh no, this was literally the question they asked me. What is important is a longitudinal study. We frequently do these studies with adults, which is great. It's fantastic. These are our easiest access audience because we have less risk. What we don't know very much of is the impact on children and how that affects them developmentally. How are we seeing individuals who are exposed emotionally? It might be a push or a shove, and our brains are resilient organs. And so now we know that it does heal. It will have regenerated pathways. What we know less of is what are some of the other outcomes that we can't account for. IPV doesn't just happen to individuals in the perfect relationship triangle, the 18 to whatever age we think that we're adulting lives. It impacts other individuals, right? The push of the mom to the child, but we treat the mom, or the push of the dad to the grandma and we treat the dad. And so very frequently we miss what I'm calling the peripheral individuals. And so that would be my goal, to have longitudinal study and to expand this research across the lifespan, because we just don't know. And thinking about what I think is really accidental, fine to link what was blast injury in the veteran population to say, hold on a second, why do these pictures look almost the same outcomes for individuals from strangulation? To say, is there a biological underpinning here? To start make that connection, to ask more questions. We shouldn't be at the stage where we're having accidental find. It should be purposeful. And that's what I would love to do. So if there's any donors who would like to support the dream of, along with making it point of care testing, we need to evolve the technology that I don't need to wait to get the IRB to have a study, to get the blood draw. That's years. Why are we not collecting other information when we come in? I'm checking your oxygen levels to say, great, you're breathing wonderful. And what other risks do you have? We check your hemoglobin A1C, not because I think you're diabetic, but I want to know, are you at risk? And then we do something about it. We have the technology to advance science so much more, and I would love for us to get there. But I think there's enough persons interested and pushing this conversation forward that I think we will.
Absolutely. And when pink concussions included brain injury in sports, domestic violence, and military service in 2012, I just got confused looks from everybody like, what? Those don't go together, and now it's so exciting to see everybody pulling those silos, which they really used to be completely separate silos. So it's so important. And I think also working in the criminal justice system and the people both in men's and women's institutions, people incarcerated with brain injury and what intergenerational trauma has experienced there, and go into a place where more brain injury happens, right? So if we could have uh, have a study that looks through the generations and sees how we can avoid at all different levels, schools, sports, juvenile, criminal level, just to have less brain injury for people and better health and care at all those levels.
And so I think if we did do that, it also, stigma remains the piece that has handicapped us for so long, because it still remains that it's fault and blame, and you're scared and it's not necessarily safe. So if you accumulate all of those, why would I even want to treat something I can't see? There's nothing to support you getting that treatment. So we need to take away the medical component to the point where we're shaming individuals to asking for help, to the point this should be a part of routine care. And I feel so strongly about that, because we're asking individuals to self-diagnose and to overcome all the barriers by themselves, where we could be helping them so much more.
Yeah, no, I definitely agree. I've never met a woman that I've talked to that I have said, it does sound like a brain injury, because women always have so many other you know, they were called stupid, they were called et cetera, et cetera. So it's the initial that I think it's a relief to find out personally that it's a brain injury, and then the next thought is, now who is going to blame me and see me not capable to take care of my children, or you know, how is this going to be used against me? Right. So the identification is so important, but then the safety around who's going to use that in what way.
Yeah, and then you'll be attacked to say if you ever make a normal, regular human mistake, oh, it's a brain, you know, they have a history of brain injury. So there's nothing to support individuals for reporting. But we're really, I think, I'm so confident that we will change that conversation if we can also incorporate some of the biological pieces that we quite frankly have no control over.
Thank you so much for your presentation, and love what you shared, and hope lots of funding comes your way. Thank you again, Tamar.
Thank you too.